background, under the FIP grant, P2 Collaborative is going to be hosting bi-monthly webinars. And 2 months ago, we did a webinar on 211 of Western New York, and this month we are hosting a webinar on addressing health disparities, promoting health equity, and implementing the CLAS Standards. So I would like to turn this over now and thank her very much for agreeing to speak today to Dr. Annette Johnson from the Office of Minority Health and Health Disparities Prevention. So Dr. Johnson, thank you very much, and please take it away.
Oh, thank you very much. I very much appreciate the opportunity to do this and to share some of what we have learned and I think may be of value to you in terms of doing the work. So next slide. I'd first like to, I'm just going to go by the slides I have in front of me because for some reason it has gone off my screen. I would first like to start with some basic definitions to kind of give some context to this presentation. And we'll start with looking at a definition for health disparities. So what are health disparities? Health disparities, as we define them by the New York State Department of Health, are differences in health among groups of people. And these differences might include how frequently a disease affects a group, how many people get sick, how often the disease causes death. And we know that there are some people who experience poor health due to certain life circumstances, such as their social economic standing, where they might live, where they age, work, and play, and other factors such as discrimination or exclusion, and we'll get into that a little bit more. So some of those populations we're talking about are racial and ethnic populations, people who live in rural areas or rural residents, women, children, and senior citizens, people who have disabilities, people with low income or considered poor. Various religious groups might experience some of these difficulties. Lesbian, gay, bisexual, and transgender individuals might be also set aside and excluded. And individuals and families that actually have mental illness, how they actually go about coping with that. We're going to move on to what are health inequities now. Next, okay. So what are health inequities? Yet another term. Health inequities are disparities in health outcomes as a result of systemic and unjust distribution of resources and conditions that are necessary. So we're beginning to understand the connection between health disparities speaks to measuring differences in health outcomes among population groups, but health inequities speak to the distribution of resources that are necessary to actually change some of those conditions that affect health. And again, we look at them as systemic, avoidable disadvantages. And these conditions, such as polluted environments, inadequate housing, absence of mass transportation, lack of educational and employment opportunities, unsafe working environments, are all implicated in what we call inequitable health outcomes, the distribution of resources. There are great social costs for these inequities, and they really, over a period of time, include threats to our economic development, our actual democracy, and the social health of the population. Next slide. So we're going to look at some of the reasons for health disparities and inequities. It's a very complex picture because those reasons for differences are complex. We're talking about, yes, individual behaviors, but also biological factors and social determinants. And those disparities often occur along the lines of what we spoke of before: race, ethnicity, and language ability. One, social, economic, and political environment, the forces within which you operate, where you live, your physical environment, geography itself, and some other structural determinants, things like institutional policies, which I think gets closer to what you're looking at as well, too. Many of these factors are modifiable, and the healthcare delivery system is part of that process, but we have to recognize that it's not something we can do ourselves. If you think of a rainbow, you think of the outermost ridge. If you don't do something with that particular outermost ridge, the individual down inside can be affected. Let's move on to our next slide. So we know that when working in public health, there are many factors that contribute to health inequities, and they all interact to create this complex set of dynamics that are part of this large puzzle. You'll see in the upper left-hand corner individual behaviors, such as unhealthy diet, physical activity, and tobacco use. And that, coupled with those biologic factors such as age and heredity, can often lead to conditions like high blood pressure, high glucose, and high cholesterol, as well as being overweight. They're also influenced, though, by education status, our social and physical environment, poverty, access to quality health care, health literacy, and those policies and practices that allow you to prevent the development of healthy and sustainable neighborhoods. It's that outermost ridge, as I was talking about. Let's move on to the next slide. Okay, so we're talking about the health. For this particular presentation, I'm going to focus on the health of racial, ethnic, and other vulnerable populations. And we're really looking at comparing the health and well-being of these populations to the general population in the country. And we notice that when we look at these, that the overall rate of new and existing disease or rates of morbidity are higher. The rate at which people die from disease or the rate of mortality is higher. And also the number of people who are able to survive, the life expectancy is less than the larger group. Let's move on. So in terms of looking at health disparities and health inequities, we see a continuing public health concern, and that's one of the reasons that we're talking about it, because many of the programs that you're working with will actually help to address this. These particular issues that we talked about previously, they directly affect the quality of life for all of the individuals in terms of those areas, their illness, their death rates, disabilities, and their ability to be productive. They also adversely affect their neighborhoods, the communities, and the broader society because, again, they're not able to be productive, and result in economic burden due to increased costs of the illness and the death as well. One of the things that happened in the year 1985 was that Margaret Heckler created a report called the 1985 Report of the Secretary's Task Force on Black and Minority Health. If you have an opportunity, please look it up. It is an 8-volume report, but there are some summary points that I think you might want to look at, because what it points out is that they identified, yes, there's disparities, health disparities and health also inequities, but they proposed actions to take for it as well. And I dare say if you look at that report, what you will find is that much of what you're working on now is also going to be what we see. It continues to be a problem over a period of time. Please forgive me, my computer just went down. Okay, we're back. We can go on to the next slide now. Again, this is the report that I'm talking about, and I encourage you to go online and look at it because I think it will give you some background as to where we are and where we're coming to reach health equity. We can move on. So we talk about promoting health equity. So what do we mean by health equity? Next slide. Health equity is when everyone has the opportunity to attain their full health potential. And no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstance. And according to the Department of Health and Human Services, they define health equity as the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally and focuses on ongoing societal efforts to address those avoidable inequities that we talked about from a historical and a contemporary perspective, and also to eliminate health and healthcare disparities. Okay, we'll move on to the next slide. So we're saying that everyone has a role to play in actually achieving health equity. We're looking to assure the conditions for public health, but we need to bring all of the partners around the table. Yes, in the health arena, we have much to do, and we can actually contribute to making those changes. But there are all of those other partners that also need to be involved in order to actually make the changes and to move the dial from the big gap that we see between the health of ethnic and racial minorities and the larger general population. So it is achieving health equity means that we need to be comprehensive and multi-level in terms of what we're doing. Let's move on. So New York State, what are we doing in New York State to actually promote health equity and to achieve that goal? Next slide. What you see in front of you looks like a giant puzzle, but all the efforts that New York State has put into place to do this. The programs that you're working with are part of that. So we address health disparities and inequities and promote health equity through multiple interventions, which focus on three main aims: improving care, improving population health, and lowering healthcare costs. So the first group you see up here is the Population Health Improvement Program, or FIP. And FIP, as you know, its objectives are to identify, share, disseminate, and help implement best practices and strategies to promote population health. Also to support an advanced prevention agenda and support and advance the SHIP, and service resources to district performing provider systems such as yourselves once they are requested. And you'll notice as we go through, I've listed both the names as well as the acronyms because we are doing alphabet soup here. The State Health Innovation Plan, which is the SHIP, has several pillars. One of them is to improve access to care. The other is to integrate care to address patient needs seamlessly, make the cost and quality of care transparent, and pay for health care value, not volume, and promote population health. And several ways they look to do that are making sure that the workforce strategies are supportive of that. Health information technology also is supportive. And there are measures and ways to evaluate how well you're doing. The next would be DSRIP, and that's the Medicaid Delivery System Reform Incentive Program. Its key themes are to integrate delivery, that is, create performing provider systems, performance-based payments, statewide, performance matters, regulatory relief and capital funding, and also long-term transformation in health system sustainability. The goal is not just to do one shot, but over a period of time to change the system. The prevention agenda, many of you may be familiar with this, has several priority areas, being preventing chronic diseases, promoting a health and safety environment, promoting the health of women, infants, and children, as we know oftentimes as a bedrock, promoting mental health and preventing substance abuse, and preventing HIV, sexually transmitted diseases, and vaccine-preventable diseases, as well as healthcare-associated infections, all those things that we need to look at that we can work on. The Language Access Program, which was put forth through Executive Order number 26 by the governor, was implemented so that anyone who needs access to services to help them understand and access the healthcare system are in place. So it offers language assistance to people who have limited English proficiency or other communication needs, informs individuals that those services are actually there, they're available, and they can tap into them. It actually indicates that we must ensure that the people who are doing those services are competent and can do them, and also that any signage or print materials are definitely in place so that individuals can access the services to understand what they're getting. And the Office of Minority Health is a key partner here because it acts as a cross-cutting issue, a cross-cutting program, which looks at all of those various programs and says, what are the cross-cutting issues? What is it we need to look at? So let's move on to the next slide. So given the nature of health disparities and health inequities, and as you can see from that, it's a multi-system, multi-level work that's needed. The Office of Minority Health and Health Disparity Prevention helps to cut across those programs and initiatives and bring them together, actually to unite them. So we'll move on and talk about what our mission is. So our mission is to serve as a statewide resource for promoting health equity across all population groups by ensuring that everyone, regardless of ethnic or racial background or the community to which they belong, has access to the resources and services they need to be healthy. And we talk about doing that by, next slide, several goals, working across the department's programs so that we can actually advance those policies and support programs and initiatives that would, over a period of time, promote high-quality, accessible, patient-centered, and culturally and linguistically appropriate care. Also partnering with partners across the board to make sure that we're able to achieve this particular aim to get to health equity. We have a Minority Health Council that helps to develop policies and recommendations for the Commissioner based on what we have learned from working with our various partners. And we've also identified what we call Section 240 minority areas, which are service areas that have non-white populations 40% or more, and target the resources to these areas. And from previous slides, we pointed out that those particular populations oftentimes have a lower quality of health, they have a higher illness rates, higher death rates, and lower life expectancy. So we really wish to make sure we move this agenda forward. Okay, let's move on to the next slide. To help us support this work, the Office of Minority Health, and this is identifying these areas where we need to target our services, we've worked with the Division of Chronic Disease Research and Evaluation to conduct a spatial analysis so we can get a better handle on where we actually need to target services. And we have identified actually 40 areas in the state. There are actually 44, but 4 of them happen to be prisons, and so that's a whole different jurisdiction within which we work. But there are 40 minor civil divisions that actually meet this particular statutory definition. So one of our major accomplishments was working with that office so we could identify those areas. And as you can see, when you look at this slide right here, what we have are counties identified. And if you look at the slide once more, the area that fits the definition, the only ones that are identified are Westchester and parts of New York City. But if you look to the next slide, you'll notice that within those areas, within those counties, we see actually pockets or areas where there are groups of people who would fit that definition. So that would be masked if we only looked at the county level, but we're taking it down to what we call the minor civil division in tracts to get a better handle. And here, what you begin to see is that within a specific tract, and a specific tract we're talking about are minor civil divisions, it's within the county, the boundaries never change, so we get a much better picture of where we need to focus our efforts. So we get an idea of where statistically, first of all, where people are located. It helps us in terms of doing assessment to determine where we need to go, and then we have a better idea of targeting services. So we'll move on to the next slide as well, too. We see that there are, again, specific areas even within those cities that we need to look at. And I'm going to move us forward because I found some of your data from Buffalo that I think is very important here, which helps us to, and will help you as well to target your services. So let's move on to the next slide with the Erie Buffalo. What we have here, and I abstracted this from the Task Force on Healthcare Disparities in the African American Community, we're looking at Erie Buffalo specific. So we're looking at the population of Buffalo and the Niagara MSA in relationship to the entire United States for the years 2000 and 2010. And you'll see that when we compare those two right there, we begin to see, we look at the Buffalo area and we compare it to the federal, it looks very similar. But when we get down to the city of Buffalo and we compare the city of Buffalo to the Buffalo suburbs, we begin to see an area where we need to focus our efforts because we have a much larger percentage of people who would fit the definition of minorities, and those would be Black and African American, Hispanic, Latino, Asian Americans, those people of Hispanic ethnic origin, and other population groups as well, too. Again, going back to our previous slide, we know that those groups oftentimes are most adversely affected when we're talking about health. And we move on further to the next slide, and we look within the city of Buffalo, and we see there are specific zip codes where those populations are in larger numbers, but also we recognize from looking at those and also from reviewing your data that there's a high concentration of poor health and related indicators for those parts of the city. So this is a way of taking it right down so the resources that you have really get at the issues that you're looking at. And I think this is, the work that you have done has been very, very, very good in terms of actually helping you to focus your efforts and understand where you might focus. So we'll move on to the next slide and talk more about the Office of Minority Health. And move on to the next slide. Okay. So we've done several initiatives based on some of that data so that we can focus our efforts. And one of them was doing a rural initiative on diet and exercise in Jefferson County, an area that very much so. Oh, sorry, the slides are out of order here. I apologize here. So some of our initiatives are actually, yeah, there we go, better. Okay, the RIDE initiative in Jefferson County to look at the community there. Again, we say rural communities or communities where we do have those issues of poor health outcomes and also poor health status. The Aquanazi Sobriety Project, which was a drop-in center, and that again was looking at the issue of substance abuse, if we remember the prevention agenda. Again, allowing communities to define their own needs. There was a First Nations Health and Wellness Plan initiative, which some of you may have been involved in. Again, that was their opportunity to identify what their issues are and move forward. The Latino Health Outreach Initiative gets at that limited English proficiency issue, because what it says is that in terms of accessing health care, we do not understand how to use your system. So this particular initiative helps people through navigators and other programs to actually understand how to access the system. To help diversify the workforce, we funded a mentoring in medicine and other health professions program to begin to introduce those subjects to members of communities that have not traditionally been in large numbers, and also, again, to allow a community to define its needs, the West African Community Health Initiative in New York City. Yes, we started with Ebola, but they said we have many other issues. Now I think we go back to the slide we had before. So the department for 2015 is looking to release the New York State Health Equity Report, which looks at the health status of people in those 240 minority areas. And with programs like yourself that have focused down, it will help us even more so. Actually supporting some of the community resident-driven place-based models. There are a number of them out there. So it's to actually make those models available to people so that they can begin from the community itself to determine where they're going and how they would like to approach the problems that they identify. Looking at community-based participatory research, making sure that they're at the table from the very beginning, so we're not defining it for them. And the area that I'd like to focus on a little bit more are the promoting the national advanced standards for culturally and linguistically appropriate standards in healthcare. So with regard to the CLAS standards, I'd like to spend a little bit more time here, so I'd like to move on to the slide that talks about changing landscape. So we know that there's been a lot of discussion recently about the fact that the United States population is becoming increasingly more diverse, and that what we have traditionally known as the United States population is changing over a period of time because we are becoming more diverse. We're much more of a land of immigrants. So it's projected by 2050 that actually there will be close to 50% or not more of the population that is considered a minority or an ethnic population, and that they have a higher rate of chronic diseases and disability. They have those higher mortality rates, death rates, a lower quality of care compared to the non-Hispanic populations in this country. So the cultural influences and health beliefs and practices, as well as their health-seeking behaviors and attitudes, are very, very critical. And when healthcare professionals are aware of the influences of culture on their actual health status, their beliefs and practices, they can use this much more effectively so that they can actually provide the services that they need. I think I'm having a little difficulty with sound here. If someone could please let me know, that I would appreciate it. I keep fading in and out.
Hi, Dr. Johnson, we can hear you just fine.
Okay, I wasn't sure because I was getting a couple of notes that sounded like I was not. So we'll move on and looking at the population itself, what we're looking at in New York State. New York State is ahead of the curve. In the United States itself, we're talking about a third of the population at this point that reflects of greater diversity. But New York State, we have approximately 42% of the population that reflects population groups that are we consider non-white or non-Caucasian. We notice that Latino Hispanic populations represent about 18% of that. The Black or non-Hispanic population is 14%. Asian population, 7%, and all of the other groups as well comprise another 2%. So in total, that's 42% of the total, much ahead of what we're talking about at the national level. We'll move on to the next slide. What I would like to point out is this. In terms of the growth within the populations, we'll look at this slide right here. While in New York State, the growth of the Hispanic population, or the percentage of the Hispanic population, is the greatest, the actual growth rate is going to be the highest within the Asian Pacific Islander population. And we know that that's a very diverse group. It's considered a racial group, but there are many different ethnic groups within, so that's something we really do need to be aware of. The same applies to the Latino Hispanic population. Yes, they are considered an ethnic group, but there are very many different groups within, and they have very many different beliefs and ideas. And we notice that the Black population is growing at a slower rate. There's a number of reasons, and we can talk about that one a little bit later, but that is a reality in terms of what we see, the growth that's happening over a period of time. And what we oftentimes see with the Caucasian population is that their growth is pretty static, but the other groups are growing. Okay, let's move on. Go on to the next slide. So I also took a slide again from your report, and this is looking at 2013 U.S. Census data, looking at the city of Buffalo in comparison to New York State and Erie County. And you notice that within your county, you are almost at the point, and within the city of Buffalo, you're almost at the 50% mark in terms of the diversification of your population with racial and ethnic groups and other population groups that are underserved. So it's very much to the advantage of people working in these areas to make sure they begin to address those issues. That's why the emphasis on class. Okay, we'll go on to the next slide. Within the United States itself, we've recognized that there's fully 30% of folks who are in or considered citizens or residents of the United States that speak a language other than English at home. In other words, English is not their first language. And I dare say, in looking at Buffalo and out in New York State at the communities that we have, those numbers are even higher. So in order to be more effective in terms of what you're doing, it is very much important for you to recognize this fact right here. Limited English proficiency is a major factor. What we find is that, for example, that there's been a large increase over a period of time. Clearly 62 per million United States residents. And if we look at the census that was done in 2010, the total population of the country at that time was 308. So we're talking about 20% of the population or more that English is not their first language. Think about that in terms of health implications. And there was a 2.2 million increase between 2010 and 2013. Again, very rapid growth. And those largest increases were in the areas of the languages, various languages of Spanish, Chinese, Arabic, and Urdu. Again, languages that we don't traditionally think of as ones that we need to be concerned about, but the languages that we very much need to be concerned about, as well as the cultural beliefs that rest behind them. Okay, let's move forward. So the federal government has introduced a system in 2000 and is moving forward called the CLAS system. And it stands for Culturally and Linguistically Appropriate Standards. And it's part of a large public health agenda because they recognize in order to reach health equity, it's going to be important to actually put these into place. Let's go on to the next slide. Originally in 2000, there were 3 themes that were in place: culturally competent care, language access services, and also organizational support. However, moving forward, recognizing that there is a need to begin to be more finite in terms of what we're doing, they were enhanced in 2013 so that the concepts of culture and health became to be much more of an inherent part of the process. Also, working with healthcare organizations so that they're considering not just race and ethnic background, but also beginning to look at beliefs, values, the institutions that people work with, the language, and where people are from, and also to advocate for a broader view of health so that it's more comprehensive, almost like the World Health Organization definition: physical, mental, social, and spiritual well-being. 15 standards, so we've moved forward. Let's move on to the next slide. So we're talking about who needs to be reached, and there are all of these folks right here. I'm not going to spend a lot of time. I'm going to move on quickly. To the next slide. And to the next one. So of the 15 standards, the first, and I think one of the most critical ones, is the principal standard, which says we want to provide effective, equitable, understandable, and respectful quality care and services. And this is within public health and health services. The next one deals with the next 3 deal with governance, leadership, and workforce. So it's talking about making sure that your organization or that organizations actually advance and promote the CLAS standards and health equity through the policies, the practices, and the resources, the way resources are allocated. Also, that they look at the staff that they're working with, and they're recruiting, promoting, and supporting those concepts through the people that they bring on board to work within the population itself in the service area, and also that they undertake to educate and train on a regular basis folks that are in governance, leadership, and workforce in those standards so that, again, we have a systemic change within the organization. Move on to the next slide. Communication and language access or assistance. Making sure that there is language assistance that's offered to anyone who has limited English proficiency so that they can actually communicate what they need, also to indicate that there is no cost to them for those services, and also to make sure that they're facilitating that timely access to the services that they need. Making sure, again, that they know those services are there, the people who are actually doing the translation, the interpretation, the facilitation are well-schooled and understand the cultures through which they're working, and that any materials or signage is easy to understand. The next area is engaging continuously in quality improvement and accountability, making sure that there are policies and procedures that are established that are culturally and linguistically appropriate, that drive the organization in the agency, that you're conducting ongoing assessments of the organization's class-related activities. In other words, not just put them into place, regulate them on a regular basis, collect and maintain reliable and updated demographic information. You want to make sure that you actually do assessments. You're making sure the community is an integral part and that there's a conflict and resolution, grievance resolution process in place to actually do that, and that that is communicated throughout the organization, and that you keep track of where the organization is in the process. I think those 15, I'll call them pillars there, are very important because it helps you to take you toward an organization that is receptive to the diversification of the population. Let's move on. So one area that we know that is very important is improving the health of the LEAP community members or limited English proficiency patients that you're serving. You want to remove the barriers that might prevent them to actually get to the service. You want to make sure that any communication between them and the healthcare providers is enhanced or facilitated so they actually know what they're getting. So it's critical that you have the cultural and linguistically services in place. They're recognized as an effective mechanism to improve the quality of care services and also to help eliminate health inequities. And we know that there are many contributing factors, but this is one of the biggest ones that we can actually make a change in. So in New York State, we have a number of things that we are actually doing to actually promote that language access. If we can move on, please. Too often, we think of the mandate as a rock on our head, something that we have to do. But we have to recognize there are both, yes, there are provisions and mandates, there are also what I call perks. So let's start, first of all, with the Patient Protection and Affordability Care Act. There's several provisions in there that actually says that you need to require that services are accessible to anyone, to everyone who is there, and that they need to be culturally and linguistically appropriate so that they can do that. Let's go back also to the Civil Rights Act of 1964, which actually required anyone who was receiving federal funds to make sure that those services were accessible to people who had limited English proficiency. What we're seeing now, too, is that the Joint Commission on Accreditation and also the National Committee on Quality Assurance are putting standards into place around cultural competency, but also around CLAS standards. Within New York State, the governor put forth an Executive Order 26, which talks about statewide language access policy, and that means that every agency within the state needs to have a policy in place and also articulate how that's going to be implemented so that anyone who accesses their services can understand and can be understood. That also will apply to what you're doing in terms of your services, yes, as a mandate from us, but also as a strong recommendation from us that you actually do this. So we want to make sure that the services are provided because, first of all, it helps to develop a loyal consumer base. If people know that you are making an effort to communicate and meet their needs, they will definitely come to your place. And it also reduces, which is a very big negative, that miscommunication and misunderstanding, the errors that happen because you really don't fully understand who you're working with. Let's move on to the next one. So I look at those last two definitely in terms of benefits, and I call them perks. You're being responsive to what's going on in terms of demographic changes in the United States, in New York State, and in the communities in which you work. You're starting to eliminate some of those long-standing issues that add to disparities in health status so that we're not constantly running against the wall and saying, what do we do about this? It helps to improve the quality of services because there's better communication. It also helps you to meet those legislative, regulatory, and accreditation mandates because you do need to meet them. You'll be in front of the curve here. Again, that competitive edge and decrease in that likelihood, the liability, the cost that come from that. Cuts your cost. So a few considerations we have here. Next slide, please. Culturally competent care. Healthcare organizations, you want to be respectful, understandable, and provide effective care so that you're actually meeting the needs of the people from their cultural perspective. Also, in terms of making sure that you're actually recruiting and retaining a diverse workforce and leadership, because that's important oftentimes to making sure that your care is culturally competent. Ongoing education and training. One training is not enough. You really need to do it on a repetitive basis and help people to be updated. And in terms of language access itself, making sure there is bilingual staff and interpretation services at no cost, but also making sure that the individuals that do it are well-schooled and they understand what they're doing. And again, materials and postage and signage, which really does speak to the community that you're working with. From an organizational point of view, moving on. Next slide. Okay. We'd like to encourage you to develop and actually put into place a strategic plan that outlines some of those policies, plans, and management accountability standards so that you're actually saying, yes, I am meeting the CLAS standards. On a regular basis, do a self-assessment, looking at whether or not you're actually meeting the standards. Do audits, do patient satisfaction surveys, things that you're doing already, how you begin to fold those in so you get that feedback that you need. Collaborate with the communities at all costs, because it's a great way to know how your services are doing. It's a great self-evaluation, it's a great evaluation process. And also letting people know that you do have a conflict and grievance process so that you're not just going to ignore what they have to say, but move ahead. So let's move ahead again once more. And let's go to the next slide. So we're talking about something called a cultural lens. What is the cultural lens through which you view your organization? And we're talking about looking at cultural competence, which is a process, and that's the ongoing process that I'm talking about, and making sure that what you're doing is translated and integrated into the practices throughout your organization, and that you're putting positive relationships into place. You're engaging the people that you want to, the families, the cultural groups, and the community, and you are really striving to improve the quality of services that they provide. And I put a diagram, we'll go to the next slide, a diagram when I talk about cultural lens. This is you at the top. And I will say to you, a cultural lens is how do I view the people that I'm working with? Not just that part that sits a little bit above the line, race and ethnic ancestry, but also what's their culture, what's their healthcare beliefs, what are the values, what are the behaviors that they have. All of those things are key and important to making sure that you are reaching the folks that you want to and that you're also being in compliance with the CLAS standards. The next slide. Next slide, yes. Okay, so what are we doing in New York State to help move the CLAS process along? As I pointed out, we're doing a lot of work within the agency, but we're also working across the agency in a multi-agency collaborative, providing the health and human service agencies in New York State. Yes, we do have a set that fit that definition, as well as the Department of Correctional and Community Supervision Services employees with training on doing CLAS. So we're looking to work with them through the Governor's Office of Employee Relations to actually put in place some resources that they can use. Again, we know we cannot do this by ourselves. So it's an orientation and training and technical assistance on actual CLAS standards, not only in terms of training staff, but also in any RFA or RFPs that go out and any other funding initiatives, making sure that, again, we're asking our partners to also look through that lens of cultural competence and CLAS. Making these trainings available and also implementing the New York State Language Assistance Program. We'll go on to the next slide. So again, in terms of language access initiatives, the Prevention Agenda Health Equity Work Group has quite a work group that is looking at this whole, whole aspect of language access initiatives, because they're very clear that CLAS is an inherent part of moving and achieving the goals that they have set into place. So within the CLAS and the language access initiatives, there is a specific work group that focuses specifically on this area and works across the board with all of the counties and everyone else that's working on the prevention agenda. The programs that you're working with, SIP programs, very much so involved in taking this forward, and that's part of the reason I'm speaking with you today, to hope that, again, that you will see how this fits into your work. The Health Workforce Initiative, really working with the workforce in the state, the healthcare workforce, not only to help them in terms of looking at how to look deeper than just what I see on the surface, but also begin to be more respectful, to really be more helpful to folks as they're moving ahead. And of course, the MRT work groups, again, this is a very inherent part of what they're doing with CLAS standards. So actually doing that and assessing where you are is a critical part of making sure that you're achieving the CLAS standards and also language access. So what I'd like to do now is to share with you just some basic templates. Many of these items I've noticed in your surveys that you've done already, they are there. But I'm going to do this as a reminder and also for a few that you might have forgotten. So we'll move on to the next slide. Doing that basic demographic survey and across the board, not just at the organizational level, but also out into the consumers and the clients. Who are you serving? Who are you working with? What are their perspectives? Doing a self-assessment of cultural competence within your organization. What happens at the staff recruitment level and at the training level? Are you staying up to snuff with what's taking place in the arena? From the consumer client satisfaction surveys, what are you learning from that? Also in terms of your language access services, do you have the appropriate signages? Do you have the capacity to actually interpret and translate services and also assess literacy for the clients that you're serving? Next slide. From an organizational support perspective, what are your policies and procedures? Are they supportive of? Again, looking at them and going more finely. What's the process for addressing complaints that come into your organization? That whole grievance process, again, is it sensitive and does it take into account who you're working with? And on a regular basis, working with your community members to do a needs, assets, and assessment so that you really know where people are coming from, what their needs are, what services are there already, and where you might need to plug into the gaps. Okay, we'll go on to the next slide. Community relations, I can't emphasize this enough. I'm not going to go over it because I'm sure many of you are doing this already. But it is really looking at the findings that come out of all of those surveys, especially the community surveys, to make sure that you are working with folks that you really need to in the community, you have active participation, and that your outreach efforts are really getting to where they need to so that you're really reaching the people that you want to. Organizations that you're working with, making sure they're also in line with what you're doing and supportive of what you're doing as well, too. I'd like to also, next slide, offer you a few resources. You may have seen these already, but a reminder that you may also tap into them because some of the tools might be really helpful to you as you do your work in communities and as you do your work across agencies. Take some time to go and look at them. Some of the work we're developing here at the state level, but many of it is the tools that are here are also ones that have been used in terms of working with communities. The actual place-based initiatives and ways of assessing. I think you will find those most useful and, again, reminders of work that you're doing already. So I'm going to thank you very much for taking the time to listen to me. Please excuse my hoarseness here and our interesting process for doing this. I hope you have learned something with the webinar that we put forth today, at least one piece that you'll be able to do some action on. And I'd like to move it forward to see if we have any questions at this point. Dead silence. I either did a great job or you know all this stuff already. How about comments?
Does anyone have questions for Dr. Johnson or comments? The lines have been unmuted.
Thank you again, then.
Okay, well, thank you.
Hold on, we do have a question.
We do have a question that came in.
Oh.
This is through the chat. So.
Okay.
Are you only obligated to provide language assistance?
No. You are obligated, yes, that's one of the areas that you're obligated, but if you look at the CLAS standards, if you notice those 15 areas, what's happening over a period of time is that there are recommendations at this point, but one agency after another, starting with the Joint Commission and others, are starting to build into their reviews looking at what you're doing in the area of CLAS. So language assistance proficiency in the state, yes, based on funding and what you're doing to move forward. But I would dare say that the rest of the CLAS standards are also beginning to be parts of requirements for organizations that are reviewing. Any other questions?
There was a question up here. Can slides be made available through email? And yes, we will post these slides to our website, p2wny.org, and we will also have a recording of this webinar, and that will also be posted to our website.
Okay, thank you. And I will point out to folks, one of my my other jobs is as a professor, so at times I get a little bit didactic, but hopefully this has been very good for you.
I think I can speak for everyone on the call and say that it was wonderful. It was full of information, and I can't thank you enough for taking the time this morning to speak with us. We really appreciate it. It was very useful.
Thank you very much. I really appreciate the opportunity.
Okay, well, if we are going to sign out, if nobody has any last-minute questions. Oh, there's one more question coming through. How can we get a toolkit?
Oh, a toolkit. I'll make it available to you. Okay, we'll get a hold of the toolkit and show you where the link is so you can actually get a hold of one of those toolkits.
That would be great. And we also have another question. Are there any higher insurance reimbursements for those providing to other languages?
I don't know of any at this point, but it's a good question for me to research, especially with the Patient Protection Affordability Care Act. There may be some incentives there, but I need to check and before I say definitely yes.
Okay, I believe that's it, and thank you to everyone on the call today. And again, thank you very much, Dr. Johnson, for being here. And everyone have a wonderful day.
Okay, thank you very much.